Okay, I think we'll begin. So, welcome everybody. This is the Institute of Health and Social Care Management. My name is John Wilkes. I have the absolute privilege of being Chief Executive of your institute. We're joined today by Jade Maloney, our Operations Manager, who will be behind the scenes, making the technicals work seamlessly, I'm sure. But the star of the show today is the one and only Tracy Green, a long-term advocate and supporter of the Institute. And Tracy, we're so thrilled to greet you today. Tracy is the founder and CEO of CQCFIT, and she's going to take you through all things Care Quality Commission related, particularly the new assessment framework. So Tracy, without further ado, I'm going to hand straight on to you. Thank you.
Thank you, John. What a lovely intro. Thank you very much indeed. So as John said, I'm Tracy Green. I've worked in healthcare management for coming up 18 years now. I've predominantly worked in general practice management. However, I have dabbled in trust, and I've also, and John and Jane might not know this, I've also managed a nursing home for just under a year within my career as well. So so I feel like I've got quite a wide range over the health and social care aspect, but healthcare more than social, I would say. I've also worked for the CQC for 11 years, it will be next month, as a specialist advisor. But because my expertise is more in general practice, then I have been a specialist advisor as a general practice manager as well. So I've taken part in over 65 assessments on site, but I've also been part of a handful as well, whereby I've been on the provider side and supported them. And more recently, there was a big group of practices in the Southwest who are a PCN, a primary care network. They had inherited an inadequate rating from their previous contract holder, and I worked with them over 9 months and their team, and after a 2-day of tough inspection, they actually got a good rating, which is almost unheard of, to kind of jump from inadequate and leapfrog RI and go into good as well. So I do some other stuff as well. I do some work with the Royal College of GPs, and I manage practices for over a decade, work nationally. I run my own business, but I'm also the general manager for BAXCQC, and that's part of Baxendale. We provide registration and compliance for all of healthcare and social care too. So that's a little bit about me, but let's get going about what we're going to talk about today. So I'm going to start just kind of giving a really quick overview and reiteration about who the CQC are, who they are, what they do. And I just thought it'd be really good to talk about what's not changed under the assessment framework, and then what has changed. I'm going to talk about the 5 key questions and talk about what makes them good in terms of their ratings, but also focus on inadequate. You will see there are absolute, differences between the two. You'll see all of that. We will pause for questions as we go along, and we are looking at leaving some time at the end for some questions as well. And I'm also going to kind of give you a bit of an overview about what's coming with the CQC as well. Now, I've tried to tailor this as much as I can, quite high level, strategic, but also bring in some real life examples. So I will try to talk about all the different type of providers as I can. But do you know what? Some of you may have some great input and insight you want to share. Please do as we absolutely go through this call. I just wanted to start off really to find out who we've got on the call. So if you've got either your mobile phone to hand, you can zap that QR code, or if you go on to slido.com and you put that number in, I'm really keen to find out where you're coming from. So what kind of provider type are you, or who you are best representing? And we'll see kind of who we've got on the call as we go through. I can see we've got some people typing there. So we've got University Dom Care, another Dom Care, Residential Care Services and Care Home, Residential Dementia Care. Yeah, my nursing home I managed was a 42-bed dementia care as well. Residential care homes, trust, we've got trust in here as well. Older people, residential, learning disability, resident. Wow, look at the massive differences in people. Respite services, lecturer. Brilliant. Arden, trust respite, autism and learning. I've just shared something on LinkedIn actually from the CQC about autism and learning disabilities. They're really massively focusing on that. I was talking to one of the directors of CQC at the primary care show a couple of months ago, and they did a whole section about making sure whatever type of provider we are making sure that everybody totally understands about learning disability and autism services as well. We've got general practice, ICB, we've got welcome. Wow, so we've got absolutely loads. We've got 24 responses. We've got somebody else still typing. That gives us a real kind of good overview here in terms of the people that we've got on the call. So hopefully this is going to be really useful for you, and do make a note if you've got any questions as we go through. So thank you. Really quick question. What would you say is your level of understanding of the CQC right now? I know it's changing lots and lots. 1 is like really, really low. 5 is high. Oh, we've already got them coming through. Look, we've got 2s and we've got 3s, and you can guess what's coming. I'm going to ask you this question again at the end as well. So the highest at the moment is kind of middle of the road. We have got one that's absolutely fine. This is no way a competition. This is just trying to understand where people are. Okay, so the average is in the middle. You've got 55% of you. Thank you. And I will be asking you to do that at the end as well. So, and we will keep hold of all these scores as well. Brilliant. Okay, let's get cracking then. So in terms of the CQC, the Care Quality Commission, who are they? You probably know this. They are the regulator in England only for health and adult social care. The 3 other nations have got other regulatory bodies, but this is England only. They've got 3 key functions at the CQC. The first one is registration. So that's if you are setting up maybe a new dom care agency, or if you're maybe a GP practice and you are merging, you need to have a new registration for that as well. The third part is all of their enforcement action. So that is where maybe they're giving you enforcement notifications. You've got breaches in regulations. It's not a nice place to be, but sadly we do get quite a lot of people in that area. But the main bit we're going to focus on today is the middle bit. It's the inspection part of it. Okay, so that's kind of where we're going to really focus. Now we know there's been lots of changes over the last probably couple of years now, isn't it? What I wanted to point out is that these regulations have not changed. Okay, I know it looks like a lot there. You're not expected to remember all of these at all. Please don't worry. I just thought I would share this, and you'll get a copy of these. Jade or the team will send them over to you. You'll get a copy of the slides. So these are the regulations where you are actually delivering as a provider under the Health and Social Care Act. Some of them might look familiar to you. Some of them you'll hear me talk about as we go through some examples. But there's quite a lot there, aren't there? There's quite a lot that we need to consider, but these have not changed, and I doubt these are going to change at all. So the other ones are the registration regulations. We've got several registration regulations. So if any of you have recently set up a new been a new provider, you'll also see things like this, that you've had to give your statement of purpose. There's a couple of things here really to take note of. Although these are registrations, things like notice of absence under Regulation 14, things like if your registered manager is going to be absent for 28 days or more, you must let the CQC know, and you must tell them what you're doing to mitigate that. Okay, things like notice of changes. So if you are suddenly going to start delivering a different type of regulated activity, you need to apply for that. And also things around a death of a service provider, a service user, you need to let them know about things like that as well. So although they're under the registration regulations, I just want to point out, don't forget those. They haven't changed, but they are still sitting there as well. So you do need to make sure you are aware of all of those as a provider. What else hasn't changed? Well, we've still got our 5 key questions. Really easy way of remembering how to remember the 5 key questions is an acronym, which is SCREW. So safe, caring, responsive, effective, and well led. Don't choke on your coffee there, John. SCREW. If you remember SCREW and you're kind of thinking, oh, I can't remember the last one, at least you've got that first letter, okay? And then you're going to be able to remember what those are. They have not changed. Your 4-point rating scale as well, they go for inadequate, requires improvement, good, outstanding. I will show you how those ratings are made up, and that did change quite recently. That's not changed. And what else did change? So the single assessment framework was brought in almost 2 years ago. You can see here, I put a strike through the word single, because when they brought this in November 2023, they wanted to bring in a single assessment framework that could be simpler, could really focus on what mattered to people, to better reflect how services are delivered. And they wanted this one framework. Has it worked? They know it doesn't work. So they brought this in, and this is still what we have got, but they have really quietly dropped the word single. If you hear the CQC talk about the framework, you generally won't hear them use the word single. So I've crossed it out, because you may hear some people talk about it, but actually it's not a single framework. We're working back towards the frameworks that we had before. So what have we got? Well, if you look at that pyramid, you've got your 5 key questions. I might ask you at the end, actually, what the acronym is, and you can pop it in the chat later on for your 5 key questions. That's at the top. Underneath there, you've got quality statements. I'll show you what those are. There are currently 34 quality statements. They're broken down over those 5 key questions. Then you've got evidence. There are 6 evidence categories. And then there's also specific evidence and quality indicators as well. And they'll also look at different data that's available to them in the public domain, and also from stakeholders too, when we're looking at specific evidence. So that was kind of quite a little bit of a change, really, because we were used to things called CLOEs, key lines of inquiries, and we haven't got those anymore. So here are the quality statements. So there used to be 27 CLOEs, key lines of inquiries. We've now got 34 quality statements. And at the end of this session, I'm going to tell you where we're probably going to end up with the CQC next year as well. And it's not 27 and it's not 34. You can have a guess if you want. You might already know. You can put it in the chat, but I will tell you at the end what they're working towards right now. So whenever I'm talking about CQC, I look at these quality statements within the key questions. Now, there is some repetition and there is some overlap. The ones at either side, safe and well led, have got 8 quality statements. They're all equally weighted. However, from my experience, both working with the CQC and with providers and all the other work that I do, it points me to say, if you can get well led and safe, working effectively, pretty much you'll crack the other 3, because they all kind of link into each other. You're not going to have a fantastic governance framework and not be caring. You're not going to have a shared direction and culture without being responsive to your team's needs or your patients' or your clients' needs. So one snippet I would say is, if you're kind of starting from scratch, learning about all of this and thinking, how do I match this to me as a provider? Look at safe, look at well led, because a lot of the other stuff will actually feed in from there. Okay, so 5 key questions, 34 quality statements. Then we've got 6 evidence categories. So these evidence categories, really, it depends on your provider type in terms of how much these will be looked at. And it also depends on each quality statement in terms of how much of these they look at. Now, the middle 2 will always happen. Your processes, I cannot stress enough, are incredibly important. Your policies, your procedures, your risk assessments, your governance framework, your appraisal documentation, all of that kind of stuff is so important. I know it's not the sexiest thing to be focusing on, but if we don't have the fundamentals there, we don't have the foundations to build the rest of the house on. So your processes, they will always look at the processes. The feedback from staff and leaders, they've put a bigger real focus on that since we've had the new framework almost 2 years ago. They will want to find out from your team how things are going. Are you well led? Are you safe? Are you caring? Are you doing all the things that your policies say that you do? And where's the evidence? They'll also be looking for the evidence at the same time, because they want to be sure that your processes, your policies aren't just written down and forgotten about. They actually mean something. So they will always look at feedback from staff and from leaders, and then over to the left, people's experiences. Now, they do this in a lot of different ways, don't they? Before they come out and do a visit to your service, they will ask you in somehow, it used to be in paper format, it's more now about online, for your clients or your patients to give feedback to them. They'll also ask you if you've got social media, which most of us do, to put something out on your social media so people can give feedback that way as well. They'll also talk to partners. So Health Watch, we know they're going, but while they're around, they're talking to Health Watch and saying what's going on here. I know we've got somebody from the ICB on here. They will talk to your ICB and kind of say, if you're ICB commissioned, what's going on? What's your feedback? If you work with other partners, so if you're out in the community and you're working with trusts or with GP practices and things like that, they'll talk to those partners as well. And then they will look at observations of care when they're in your service, and really important, what I call the so what, the outcomes of care as well. So if they're coming into social care environment, they will be looking at your care plans, and they'll be making sure that that is all absolutely spot on, whether it's paper-based, electronic-based. They'll be looking at all those outcomes of care. If they're going into maybe a hospice, as an example, they'll be looking at people's wishes and saying, did they actually get the wishes adhered to that they wanted? So those are some of the examples in terms of the how do they actually assess those 34 quality statements. What else has changed? Well, they said they were going to change to more of an ongoing assessment. So they are looking at more of an ongoing assessment route. However, they have tried to do that whereby they would go out to a provider and maybe just look at 5 quality statements out of 34. Now, I look at ongoing reports on a monthly basis, and I know that doesn't work. They know it doesn't work, because you have providers then that aren't allowed the evidence there to be provided so that their rating can change, because they haven't actually assessed enough to show that they could move from their RI rating up to good rating. And I know particularly for social care, there's a lot of you out there that haven't got the ratings that you currently deserve, and you are still waiting for the CQC to come out and reevaluate that. So when they come out and reevaluate, you want them to look at all of it. So they were going to go on an ongoing assessment, and I think they will carry on having this risk-based approach. They will compare. So if they've got one slot to come out and kind of look at, say, one GP practice, they will have a look at those practices in the area. They will look at all of their intelligence. They'll look at previous inspections. They'll look at any complaints that they've had, any notifications, and they'll go, right, which one do we think is the biggest risk? Right, we're going to go to that one. So they are still doing that. They did have the portal to upload documents and the evidence, and I'll be interested to get anybody's feedback on your use of the portal, but they withdrew that for new registrations from November, and many people just aren't using that for submissions because it's just not fit for purpose, and they know that. They have changed how their ratings are calculated. I've got a slide just quickly to show you in a moment. And they did say that ratings could be changed without a full on-site inspection. Now, I personally am not aware of any of them doing that. And I think that's because they knew that it probably wasn't the right thing to do, because they weren't doing that full inspection. So actually, was it going to be right and fair and proper? And the answer may have been no. So as far as I'm aware, they didn't actually change any of those ratings without going on site. So how do they carry out? Well, pre-COVID, it was usually once up to every 5 years, and it was on site, and then they had a published rating. If you were rated good or outstanding, we kind of knew in the industry that you'd be kind of getting to 4.5 years. You go, oh, I need to prep now for my CQC inspection. It's going to be coming in the next 6 months. It's really not like that anymore. After COVID, well, through COVID, we started with the annual regulatory review, and that was a remote monitoring service. And then 21, there was a monthly remote review piloted in July, and then it was rolled out nationally, but there were no rating changes, and it was a very, very light touch. So then they started some face-to-face inspections and then some monthly remote reviews. Before then, in November of 23, the new single assessment framework started, and then that was rolled out in spring 24. So we've been going for, what, 16 months, something like that. Then the Penny Dash report came out and they said, actually, we don't think we should be allocating scores at evidence categories. Remember those 6 evidence categories I showed you? We don't think that's working, so let's stop doing that. Okay, so they stopped that in September. And then in November, they went, oh, the portal's not working. I mean, I know from dealing with registrations, we've had clients that we put all of their registration through the portal and it just got lost. We had to do it again through an online form. Through a Word document and then send it. So, you know, I think it probably was the right thing that they did to stop the use of the portal. And if you read any of the CQC literature that comes out, you know, they spent billions and they need to spend a lot more to get it working again. So that's kind of how they were carrying them out, and it will still partially be focused on where there is perceived risk. So if you're getting complaints from your patients, service users, family members, partners, third parties that are going directly into the CQC, if you are having lots of changeover of staff that's kind of made aware to the CQC, if you've got safeguarding issues, lots of freedom speak up stuff that kind of carries on and goes somewhere else, all those kind of things could potentially lead to an inspection. Now, lots of people say to me, oh, we've had our registered manager change, so we're going to get an inspection. And my response to that is, why do you think you're going to get an inspection? Because we made a change. So I kind of talk to them about all of this. There's no actual framework that is set in stone that says, you do this, we inspect. You do that, we inspect. It is a real combination. They might do that in the future, but they're not there yet. So it's usually a combination of lots and lots of things. And I have to say, there are still providers out there from as far back as 2016 that have not had an inspection, which is just awful. And new registrations as well. People say, oh, well, I'll get my first inspection within a year, won't I? And I'm like, well, you should. But I know there's new providers out there that have been going for up to 3 years that have not had an inspection yet. But I think with the way that this framework is, and I think the way they're going to go forward, I would say, don't sit back on your laurels with me saying that. I think we should be ready absolutely all the time. Because there are the 2 different ways they're carried out, routine and expected, and also based on perceived risk. So those are the 2 ways. If you're sitting there as a live provider, you haven't had an inspection since before 2020, you will be in that top group of people. Okay, you might not be right at the top of that list, but you will be in there somewhere, because they know they are the regulator. They're there to keep people safe, and they can't actually do that if they're not coming out and seeing us, can they? So when you're going to have an inspection, you're going to get a notification of assessment. They'll usually phone first, then they'll follow up with the email. It's usually to the registered manager. In general practice, I know a lot of the time they will then contact the practice manager, but generally speaking, their interaction is mainly with the registered manager day to day. They'll usually ask for a data request, a PIR, provider information request, loads of information they ask there, which is why I'm saying be ready, because you do not want to be scrabbling around getting your policies in order at this point. You've got lots of other things to do. Now, depending on your type of service, they may allocate a remote specialist advisor. So I'll talk GP here. So in a general practice, we've got a clinical system that we use to hold all of patient data records. They will get a GP specialist advisor. So I'm a practice manager advisor. It wouldn't be me, it'd be a GP. They will get access to those systems and they will run searches, and they will be looking at high-risk medications, medication reviews, all those kind of things, and they will kind of go, okay, this is what we're finding out here. That may not happen in all providers, okay, but they'll be largely looking at medication and actually seeing how safe that is. In that case, they'll arrange a feedback session then the on-site visit. A draft assessment is shared for factual accuracy. You have 14 days to give that back. Now, if you don't like what's in the report, it depends what's in there if you can challenge it. If it's factually inaccurate, so they say your provider is in Norwich and it's in Nottingham, absolutely, you tell them they got it wrong. But if they say you didn't have all the required HR files available on the day, you didn't have all the HR files available on the day, you cannot then challenge that, okay? Because that is true. And then they'll actually finalise it, they'll publish it. And one of the things within that regulations, if you saw it earlier, you must publish your provider rating. So it must be in your service if you're an on-site service, and it also must be on your website. The reports have been streamlined a bit. They weren't doing all 34 quality statements, as I said, but generally they will be. The only time they may not do that is where you've got a focused or a follow-up inspection, but they will tell you the areas they're going to be looked at, and in which case they may carry forward scores from your last report. But again, I guess they're going to look at all of this when they're looking at how they're going to work. And then your scores will be aggregated and it will give your overall score. So I'm just going to pause there before I go in to talk about this very colourful slide about where we are in the last month, to see if anybody has got any burning questions before we move on. Oh, that's interesting. Rachel's put a note in to say they had a completely unannounced inspection, residential, recently, and no prior notifications to the on-site visit. Yeah, that's interesting, Rachel. I'd be interested to know how you got on. Generally speaking, they can do unannounced. Most of them are announced, and unfortunately, it happens to be more in the adult social care where they do the unannounced inspections. So hopefully you got on okay. They could maybe be able to tell you what prompted that, but yeah, typically they try to do it announced because they want the people there, don't they? They need to know that people are going to be available to talk to them. Okay, I can't see any other questions there. If you want to stay on at the end, Rachel, we can have a chat about that if you would like to. That would be absolutely great.
Tracy, could I just mention, I'm sorry to interrupt you, could I just mention Andrew's point? He's head of health and safety at I think that's All England Lawn Tennis Club. They're going to be registering with CQC in 2026 regarding provision of medical services. Now, clearly that's very different sort of an organisation to, for example, a domiciliary care provider or indeed a primary care provider or hospital. Does the CQC acknowledge and take account of the fact that there will be these very different types of organisations who are required to do a CQC registration, and therefore some of those assessment points that you've referred to earlier would be very difficult for them to be able to address evidence towards, for example?
Absolutely, and thank you, Andrew, for popping that in, and John for picking that up. Yes, interesting. In my BAXCQC world, we've spoke to a couple of events companies, and this is why the CQC know that the model of care is moving forward at such a pace that actually the regulations don't match and the questions don't match, which is partly why they're going to move away from this single assessment framework. It just doesn't work. But what they would do in your situation, Andrew, is, or any other kind of more niche areas, is that they would look at, well, what does matter? They'd still look at the 5 key questions, and on your application, if you've started looking at it yet, they would be saying, how will you make sure it's safe? Well, you would tailor your answer based on your service, and that's exactly what you would do for the 5. And then you would end up having a registration interview with the inspector, and actually you'd probably end up starting by going, let me explain about all of my service first so that we make sure the answers and the questions are appropriate. But you're right, John, it is a bit of a minefield now, because we haven't just got your basic kind of standard providers that we used to have. I know when I was chatting with one of the directors, as I said earlier, at the primary care show after they did their event, you know, they were saying people are buying vans, like old converting Tesco vans, chucking a first aid kit in the back and saying, we're an emergency kind of transport service, and she was just like, it's just horrific to think these things out there. And also, if you think about things like the medical aesthetics world, that's a complete other area to open up. But if you're a registered healthcare professional, you need to be CQC registered to kind of do ear irrigation. If you're not a healthcare professional, you don't. Where's the logic in that? There is none. It's because of the way that our model of care and the way that we work is moving forward so quickly. But to answer the question for Andrew, they would definitely, it sounds so exciting, doesn't it? But they would definitely need to understand your organisation, which is when you'd fill in your statement of purpose to explain what you do. And then you would say, this is how I meet the standards. And hopefully you'll have a sensible registration inspector there, Andrew, that actually listens and understands to what you're doing. Does that answer your question, John? Fab. Okay. Shall we crack on? Right. So this is last month's published reports. Literally, I did it yesterday, so it is hot off the press. And you can find this out as well. You can go onto the CQC website, scroll all the way down to the bottom, and then you can see our recent checks on services. And you can do last week, last month, all. You can kind of pinpoint it down to all the different types of services. And you can go, oh, I only want to look at hospitals, and I only want to see what's outstanding, and you can pin it down. So you can see there were 475 in the last month that were published. Now, that is by nowhere near the amount they should be doing. It's better than it was, but they are way, way behind in terms of what they're doing. You'll also see there were 96 there that weren't rated, and that's for various reasons. Some can be because actually they are massively in breach and they're looking at imposing prosecution. Some can be because they're changing hands, and some can be because they just need more information. So with those percentages there, I've taken that 96 out, and you can see from all of the services, 2.6 were outstanding, 61% of them were good, 29 were RI, and 7.1 inadequate. It's a little bit of rounding up there to do. Just to mention dentists, I don't think we've got any dentists on here, but they don't get rated. They get yes or a no. It's kind of a pass or a fail, and prison services are the same as well. So they're not actually showing in terms of what their ratings are. Now, I have broken it down there by provider type, and apologies to the care homes and the home care agencies that are on here, because you might go, oh, we're getting picked on. It's not. It's purely just for me to pull this out and show you, but also care homes were the most assessments that were actually published as well. So care homes and home care agencies, you can see there, although you're highest by inadequate provider type, you are by far the biggest group actually that we're seeing. And I get it, I totally understand. It is so hard within a tight financial envelope as well to do absolutely everything. So you've got 4 were hospital, 1 was hospice, and 1 was rehab. An outstanding provider type, you've got 3 which were hospital, 3 practice, 2 home care, and 2 hospice as well. So do go onto the website and have a little look if you get a chance. If you want to have a little play, you can actually see what those are. Now, the quality statements, I'm going to go through each of these 5 key questions and very briefly talk about what we need to do for all of these areas, and I'm then going to show you some of the reasons why some providers, and these are from reports that are out there, were inadequate or requires improvement. Okay, so in terms of safe, you can see what safe means there. We kind of know, don't we? It's a priority for everyone. Everyone's always protected, and liberties are protected as well. Now, when we say safe, and everyone, this isn't just your patients or your clients, this is staff as well. And if you're employed, this is you too. So there are 8 quality statements here. Safe environment is absolutely crucial, of course. So have you got all your fire checks? Have you got your PAT testing, your defibs are all there, all that kind of thing as well. So is your environment safe? Safeguarding, we all need to make sure we know who the safeguarding leads are. And in terms of infection prevention and control, we need to make sure that we have a lead for that. There's some great things out there, some kind of great tools you can use to go through and do an IPC audit. Make sure that you follow up on that audit. In terms of people, we've got Regulation 5 is fit and proper persons for directors, and that's for anybody that's registering to be a registered manager. But under safe and effective staffing, this is also making sure that all the staff we have are safe and effective. So this goes all the way back to recruitment. It goes to induction, to ongoing CPD, DBS checks, making sure then we've got the right type of people in the right place at the right time. It doesn't matter what kind of provider you are, that stands for absolutely every provider that we've got. Whether you've got 2 people or 2,000 people employed, it is absolutely the same. Your safe systems, pathways and transitions will be slightly different for each provider, but overarching that is, have you got things in place to make sure that when you ask for, say, a referral to be done, that it is done and it's done in an effective way. And your meds optimization is a really, really, really big aspect, because they want to make sure that if you are prescribing or giving medication, it's done in a safe and effective way. So for GP practices, this is more to do with prescribing and ongoing medication reviews and high-risk medications, and looking at alerts that are coming in, and we're checking patients and saying, do they need to have a change in their meds? If you're in a care or a nursing home, or even in like domiciliary care, it may be around your Mars charts. Have all those been updated? Are things being given as they should be? So they're really, really big areas. So safe is a massive area. So I would say absolutely to kind of start with one of these. You're involving people to manage risk, absolutely. And your learning culture comes from complaint management, significant events, never events, all those kind of things. So when has it gone wrong? Well, here you go. You can see, and this is information I've taken from some reports that have been published. You can see there, you've got pretty much everything: medicines, recruitment, staff, high-risk meds. There's one there in the middle at the bottom. They're in breach of legal regulations, safe care and treatment, safeguarding service users from abuse and improper treatment, and then also around infection prevention and control as well. So that gives you a bit of a flavour, but you will see they are the polar opposites from the one slide to the other. Let's quickly have a look at well-led. Governance, management and sustainability. Governance is Regulation 17. I have got a slide separately about that. But having a governance framework is absolutely essential. That is your umbrella to make sure everything else works effectively. Capable, compassionate, inclusive leaders. Your freedom to speak up. You need an internal and external. You don't have to have internal, but you definitely need an external freedom to speak up guardian. Why? Well, think Harold Shipman and things like that have gone on in the past. You need to be able to go to somebody else if you're concerned and your direct manager, your registered manager, you don't feel is acting accordingly. Environmental sustainability, they're only really looking at that for trusts for year 1. We are through year 1 now, and I've not heard any more about that, but I have seen what they might be doing with that moving forward as well. But ultimately, your well-led is, have you got a business plan? Have you got a business continuity plan? Have you got really good learning and innovation? Are you inclusive? Do you, look at making sure you have a diverse population for your workforce, if possible? And then you can actually get somebody to speak up if they need to as well. Here we go. Inadequate, it just kind of comes again for everything that I've said. There was no leads, no learning and improvement, nothing learned from complaints, nothing about monitoring, not high quality care. They were in breach of the legal regulation for governance, which is Regulation 17, and there was nothing in place there for freedom to speak up. So you've got 8 there for each, and then we move on to responsive. So then we go 7, 6, 5. And you can see here, responsive, we are looking for, people and communities at the heart of what's being delivered. People's health and care needs are understood. We've got active plans, care plans in place. And also we make sure that everything is accessible, including physical access as well. So we want to make sure there's equity of access as well. So if you need somebody to come for a hospital appointment, what happens if they're not very mobile? What happens if they cannot walk very far? How are you making sure that that person can actually come to their appointment just the same as somebody else could, should they not need other support in terms of them walking to their appointment? They expect us to be listening to and involving people. So how active are we with our service users or our patients to get feedback? You know, how was that for you? What can we do differently? And when we're providing information, how are we providing it? Is it in the best way for that patient or that service user? Have we got things in Braille? Have we got things in different languages? It's all those kind of things. And a lot of it is about being able to access services. So in terms of inadequate, we got patients unable to access services in a timely way. If your patient satisfaction has declined, you know, we're all monitored, aren't we, in terms of patient satisfaction. And then if we've not got improvements around kind of complaints and governance and learning from those things as well. So that's 3 out of 5, and you'll see we're getting less and less now. We're going to 6 now for effective. And things here are like getting consent to care and treatment. Now we might go, yeah, of course we do. But it is about making sure that everything is written down. There's a process, there's a policy for absolutely everything as well. So we do actually reflect all of that when we show that to people. We want to monitor and improve our outcomes. So if it's a clinical decision, how are we making that clinical decision? Is it based on nice guidelines? What else are we basing it on? Are we keeping up to date with all of that as well? And how are the staff and the teams and the services really, really working together? Because all of this will come through to make sure that we can give service to people and we are there when they need us as well. So in terms of inadequate, again, we've got the fact that patients are able to access the service in a timely way. And also we've got here patients received ineffective care and treatment that did not meet their needs. Now, this was from a GP practice, and this was around long-term condition management. So that's your diabetes, your heart failure, your asthma, all those kind of things. And this particular practice, we're not recalling patients in an effective way and keeping up to date with nice guidance. So that's what that one means there. And it's going to be really similar if you're dealing with any medication at all. Are you keeping up to date with all of that as well? And then you've got a few others as well there. And some of these are around staff things. You know, probation reviews aren't carried out. Training wasn't carried out. The induction documents, yeah, they're there, but they weren't personalised at all. And then your last one is your caring. So this is around your privacy, your dignity is respected. We want to take people's wishes into account, and we want to support people to live as independently as possible for as long as they can. So we want to be able to evidence we're treating people as individuals. Again, that comes back to care planning. What have we got written on their care plans? Are we showing that we're treating everybody individually? It's about giving that kindness and compassion and that dignity and saying, you know, do you need a chaperone if it's an intimate examination in that kind of setting? And also giving independence, choice and control. If you cast your mind back to COVID, you may remember there was a massive issue where allegedly some adult social care services were putting DNARs in place, do not resuscitate, in place for people that were in nursing homes. And there was a big uproar to say, well, just because they're older, it doesn't mean that they should have that. So there was a big thing that happened there with CQC to make sure it's about independence and choice and control. When we come to end of life, where do we want to have our end of life? If we want to have it at home, let's make sure we can have it at home. Let's get everything in place because we want to treat people as individuals. But it's also about responding to people's immediate needs and making sure there's people there when they need them. And then again, you've got here inadequate and requires improvement. People didn't always feel well supported. They didn't feel like they were treated with dignity and respect. And they did actually have a breach of legal regulation as well for that as well. So that is a real quick whistle-stop tour about the 5 key questions, because I could talk for a long, long time about that, and I'm not going to. Now, I said I was going to focus on Regulation 17. I would like this ingrained in your brain if possible, because this is such an important regulation, good governance, because governance is, simply put, the way you do things around here. But it's about having a process, it's about having policies, procedures, audits, improvements, and also being able to mitigate any risks as well. And the CQC definitely look at continually evaluating and seeking improvements. So I would really have a look and say, how are we working in our provider to actually meet regulation 17, which is good governance? So I said earlier I'd let you know how it's changed in terms of the inspection and report. So we've still got those 4, inadequate through to outstanding, but this is how they decided to change it when the single assessment framework came in just under 2 years ago. We now get a score. So for each of the quality statements, we get a score, and you will get a 1 to a 4. And then all of those are aggregated, and with those aggregated scores converted into a percentage, that's how you get your overall. So overall, if you get over 87%, you get your outstanding. It's a massive area there, isn't it, for good 63% to 87. And I think this is a bit like Marmite. You're either going to love it or you're going to hate it, because if you got 63% and got your good rated, and you could publish your good rating, you probably go, phew, thank goodness for that. But what about if you got 87? Would you be really cross because actually if you got an extra percentage, you'd get outstanding? I don't know. It depends how you look at it. But they'll look at the overall service rating, and that is kind of when you get your overall result as well. And all areas, although you've got 8 in some and 5 in another, they are all equally rated. So we are coming towards the end now, and this is just a snippet that I've taken from the website. I have taken the hospital name off there, but this is what one of the newer reports looks like if you've seen them. Now, this is a hospital, so they've got lots of different areas that they've looked at. It may be you will only normally have 2 or 3, but it depends. But I've picked this one to show you all the different dates that they've looked at things. So you've got some there where they've looked at, say, outpatients in 2019, their critical care in 2022, and then they've gone back and they've looked at maternity just last month, and that's what's prompted this one to be published, and it still requires improvement. And you can see there you've got a couple of good, you've got RI, you've got inadequate, but overall, because of that, the way they aggregate the stores, they've overall still got inadequate, so they will massively have their heat on them. But if you've not done already, you can really easily go onto the CQC website, look at any provider you want to look at. So the themes that have come out, and they have not really changed, I would say, in the last couple of years. Governance, I would say, is huge, absolutely huge. Your significant events and your never events is still a big theme. Your complaints. And what they will do is they will triangulate. So they'll look at your policy, say for complaints. Then when they come into your service, they will say, well, can you pick me out a couple of recent complaints that you've had? And I've done this working with the CQC. Let me have a look at your patient or your service user's letter. Okay, I've read that. Now let me look at your responses. If you've got an interim response and then a final response, and they will triangulate and make sure that, one, you've acknowledged everything on the patient or service user's letter, but also it matches what you say you do on your policy. So that's why I've kind of put that as one of the themes, because a lot of the times there's a mismatch there. Safety alerts with the MHRA, all the alerts that come out, whatever area we're in, we're going to need to know some of those, be it medication or if it's premises, to manage those. Safe recruitment checks, sometimes we miss those. So if your recruitment policy says we always get 2 references, you get 2 references. What happens if you can't get one? You risk assess. And if it's somebody that you've known for donkey's years, you go, do you know what, I'm quite happy having one, or they've just come out of university or something like that, you have to do a written risk assessment for that person and keep it in their file. Okay, so that's something you must do. Mandatory training is a massive one. The amount of practices I go into support and also see on reports where mandatory training isn't up to date, things like safeguarding as such, that's so important. I'll look at that. The ongoing CPD, identify and managing your risks. You should have a risk register, and then you've got your mitigations on your risk register, and then your revised score. Effective prescribing, access, your patient involvement, and also monitoring those referrals that you're doing, depending on what service you're in as well. So that's a bit of kind of where we are. Where are we going in the world of CQC? Well, I've already said, haven't I? The CQC recognises this signal assessment framework does not work. So they're currently working through something called the CQC way. I have managed to go to a couple of their engagement events in person and online, and they are asking for engagement and collaboration to have a redesigned approach. They're going to potentially start talking to people about that autumn, which is now, and then they're looking to actually implement that in bite-sized chunks from 2026 onwards. What else? They've had a new CEO appointed towards the end of 2024, and as a result of that, they've got a new leadership team and 4 new chief inspectors have been appointed. They've got task forces to clear their backlogs. They have backlogs of everything, absolutely everything. So they're working from that. And I did say you could guess how many quality statements might be left. You can see there they're currently suggesting 23 quality statements. They're going to amalgamate some, abolish some, to make it a little bit more straightforward. And hooray, they're going to have a new IT system as well. So there's lots and lots that's going to be changing. What won't change is the regulations, because they're there. Unless they change the Health and Social Act, then that's all there. So how do you prepare? Well, I've given you a few snippets as we've kind of gone along, but this is kind of my summary. I would say, you know, be prepared, be knowledgeable, engage your patients or your service users, engage your team. You can't do it all on your own. Absolutely not. No matter what service you are in, you good governance, and utilize AI and digital innovation as much as you can as well. And really try to understand what good looks like as well. So I'll put this on here, but I'm just going to open it to questions because I'm aware I have talked a lot. Yeah, I can see Jay, thank you, said there's going to be some Q&A. So if I ask you to have a look at that question as well. So this is looking at where your understanding was before and where it is now as well. There are a few questions, so I'll have a little look at that as well. I'll start picking up these questions, John, shall I? Okay, so Lucy, do CQC take into account the financial constraints put on providers by local authority? That is the biggest barriers to meeting these quality statements. You know what, I'd love to say yes, but no, they don't. They didn't give any kind of flexibility around COVID or anything. Why? Because they are the regulator and they're there to keep people safe. So sadly, that's not something I've seen happen at all, because you are the provider at the end of the day. Will they publish actual percentages? They don't publish percentages, but what they will say is, oh, you have scored 24 out of 100 or 57 out of 100. And they do show that under every quality statement. Okay, so if you really wanted to, you could kind of go through and do that as well. You missed the well-led inadequate. We'll go back and do that once we've done this slide. No worry. Okay, let's see if we got some coming through. Oh, wow. 85% of you have moved to a 4. That's incredible, John. That's less than an hour. That's amazing. So yeah, we've still got 15% that's sitting on a 3. That's okay. I mean, you know, it hasn't even been an hour. You know, there's only so much I can kind of cover in that time. And you know what? I certainly wouldn't expect you to be looking at 5s at this point anyway, because there's still so much more. We've just literally skimmed the surface, haven't we? So shall I go back to that well-led inadequate? Because I know someone's asked for that. There we go. I'll pop that there. You'll get a copy of these as well. And then, John, if there's anything you want to come in on, or if anybody's got any questions, if anybody's brave and actually wants to speak, we're happy to have verbal communication as well.
Thank you very much, Tracy. Goodness me, that was a romp through what the CQC have been up to. I suspect the reason there aren't any 5s there is we can understand what the CQC is now trying to do, but there's not necessarily, therefore, a presumption that we agree with what they're trying to do. And that I think that's probably why the 5 bit is probably missing there, because it's still extremely complex, and there's still a lot of change taking place. There've been far too many leadership changes within CQC and people resigning, in my opinion. But look, if we have to have a regulator, then and it's going to be based around inspection, then it is the CQC. That's it. We just have to embrace that and get on with it, I guess. So would anybody like to ask any further questions of Tracy? Feel free to either put it in the chat or unmute, and we will go from it. So I suppose that the big one is this issue of financial constraint, Tracy. So the CQC looks very one-dimensional to a particular provider. I suppose, does the CQC take a more holistic view of the environment in which that provider is trying to deliver services, some of which, if you label it with whatever you label, or you give it the rating that you give it, that may be beyond the power of that provider to control because of the environment in which they sit. And that seems very unfair to then, make the scapegoat for that the provider themselves.
It is really tricky, isn't it? And I think this goes across many providers. I know in terms of social care, it is really hard. Obviously, I spend a lot of my time supporting general practice, and there's such a tight financial envelope there as well. Yet the expectations and the requirements are really, really huge. And I think it's about looking at, well, what are contractual requirements? What do we need to give? And then what do we need to do that is good enough? And a lot of people say to me, how do I get outstanding? And I'm afraid I say, why do you want to be outstanding? Because actually, it is so damn hard to do that within the tight financial restraints that people have. And for me, good is good enough. And, you don't have to agree with my stance on that. But I think, last year's outstanding is this year's good, because things change so much over such a period of time. But in terms of the whole kind of financial constraints, they really don't. And it is a real worry, I think, particularly in social care, that there isn't enough money in the budget. And I think it's about maybe organisations like the IHSCM that can help to, kind of fight to try and get the right amount of money, say from local authorities, so that we can pay the carers and the nurses, etc., the right amount of money, so that we can deliver. Yes, Lucy agrees with me. So we can deliver that right service and care, so that when the CQC come in and go, yes, they've all done their mandatory training. Oh, yes, and they've gone and done some lovely CPD, because we've got the funding for backfill. And I think it is quite scary at the moment in many health sectors that there just isn't enough money to go around. Don't have a magic wand, unfortunately, to fix that one. But I totally agree, and I'm not going to sit here and pretend that all is in rosy. No,
I think that's a very fair answer, and I think that if I could paraphrase what I've heard over the years, it's that the CQC have too often just put the hand up. I'm not interested in listening to your rationale as to why. Yeah. I literally dispassionately and coldly review versus the regulatory framework that I'm required, and that's really, I suspect, what has led a lot of providers to view them with great suspicion and frustration over the years. So hopefully that will be ultimately we're all trying to deliver safe services, I think. And
absolutely.
I think if we all work together in that regard, that would be a very welcome development in terms of CQC's relationship with the providers. But there you go. Matthew, you've just very quickly got in. We've only got about a minute to go, but we'll try that. Could you talk about AI quickly, Tracy?
Yeah, it does depend on what kind of organisation you're in, doesn't it? I think I think if you look, say, at general practice, where I spend a lot of my time, there's been a huge amount of AI innovation. So simply in terms of, the letters that come in, this is all the unseen work that nobody really kind of knows unless you work in it, kind of sees that goes on. So it's all these discharge letters and all that kind of thing. Well, people were physically picking those up, reading them, coding stuff, scanning them in. Well, now there's AI technology doing it. Okay, it needs to make sure that it works and it's effective, but there's over 6,000 practices in England, so we can make sure that it's at scale as well. But it's making sure then that somebody can actually go, oh, here's a bunch of letters, let me scan them in. It's going to code it, it's going to tell me where it needs to go, and then if there's other things that need to happen, it's going to kick it out at the end of it. So it's those kind of things. And in terms, again, as general practice, it's around using things like the online consultation platforms rather than everybody having to be sitting on the end of the phone or at a front desk. So those are my kind of examples. And I know in care planning you can use online care planning rather than sitting there with your pen and paper as well. So there's probably lots of other examples, but that's just a couple that come to mind, Matthew.
Tracy, we're out of time. Can we record once again our profound thanks to you? I can see a lot of people are putting some nice comments in the chat about how much they found that helpful and valuable, which is what it's all about. So once again, huge thanks to you. And
my pleasure.
If you can engineer a meeting for me with the new CEO, that would be even better. So I have a chat with them about how the IHSCM might support them and able to provide some feedback for them. There we are. All right.
Fabulous. Have a great
thanks
afternoon.
So much, everybody. Have a super rest of the week, and thanks for coming in today. Tracy, once again, box office. Really appreciate it. Bye-bye.
Thank you. Pleasure.